Today I've been asked to talk about cardiac surgery and specifically about the patient's journey of cardiac surgery. We just had a fantastic presentation from Mr. Adam about the latest technology and future procedures that will be minimally invasive and perhaps will impact greatly on our patients. But today what I would like to do is just to start with to show you a very short version or the trailer of the movie that some of you had already seen earlier today, some of you haven't. It's a 3-minute introduction to cardiac surgery. Then I would like to go on to talk about how did these young patients get there. Chosen two movie stars from that documentary, Brooklyn and Liddy. And today I would like to share their journeys with you and just to talk about how did they actually get to open heart surgery and what it is that together we could have done to prevent that. Now, both of those young kids travelled on a gravel road, unpaved road. They had no warning signs. And their journeys are completely different. So we're going to take two different journeys and see how they do share some common features. I'll start with young Brooklyn. Brooklyn is 9 years of age. She had her first episode of acute rheumatic fever at age 6 in 2013. And she had pretty classic presentations. She had presented with polyarthritis, hot, swollen, and painful joints. She had a fever. She had raised inflammatory markers and a positive streptococcal titer. Now, those of you who went through the guidelines earlier and today, you would see that she met the diagnostic criteria for definite acute rheumatic fever. But in addition to that, she also already had shortness of breath on presentation. Now, she underwent an echocardiogram which showed very severe mitral valve regurgitation, and the echocardiographic features were highly suggestive of a very acute episode. She had no scarring or restriction of leaflets. All the stuff that we saw on echo suggests that this was a first-time episode of rheumatic fever. Now, young Brooklyn is from Galabinku or Elcho Island, which is a really remote community in the Northern Territory. And her family had already relocated to Darwin because her father was on dialysis for kidney disease. So this is coming back to the story of the strep germ and how it impacts on families, just what Bart was talking about just a few minutes ago. So there's a total of 11 people in the household. mum and dad and 9 kids, and that's on a normal day. But on some days there would be 15, sometimes 20, and sometimes up to 30 people in this household. And this is the background of Brooklyn. So as I said, in 2013, the diagnosis was pretty straightforward. Brooklyn received treatment according to the Australian guidelines, management guidelines. So someone with severe rheumatic fever should have a dose of penicillin injection to eradicate strep. So she had that. She had bed rest, not evidence-based, but her heart failure was so severe that it is appropriate to restrict her activity, given that she had acute inflammation of her heart. We know that steroids are not evidence-based, but given the severity of her heart failure, she also underwent a course of steroids, high-dose steroids for 4 weeks, in addition to heart failure medication, which is furosemide, spironolactone, and ACE inhibitors. With all that on board, she made some quite positive improvement, and we weaned the steroids. But as soon as the steroids were weaned, she had a rebound of rheumatic fever, once again high fevers, high inflammatory markers, and being very irritable and cranky on the wards. By this stage, Brooklyn had been on the wards for almost 2 months. Now the father, remember, he's on dialysis, so 3 times a week he had to attend hemodialysis. Mother was stuck in hospital all day long, and 8 kids at home by themselves. Now, so the father not only had to take over the household duties, but he had to learn how to cook, feed the other kids, go shopping, in between looking after his own health. And certainly Brooklyn just wouldn't have a bar of her mother being away from the ward. So you can just imagine how much stress this is placing on an entire family of just having one child with rheumatic fever. Unfortunately, Brooklyn's heart disease progressed. She developed extreme pulmonary hypertension, very severely dilated left ventricle with a failing left ventricle. So we actually had no option but to refer her for cardiac surgery. And exactly to the day on her 7th birthday, she was accepted for open heart surgery. Now, during this stage, she was still in the acute phase of rheumatic fever. Mum and Brooklyn went down to Melbourne, underwent open heart surgery, which you will see in the documentary, or those of you who have already seen it. And the operation was a great success, fantastic surgery. But when Brooklyn returned to Darwin 10 days after her operation, nothing had changed. She still had rheumatic fever. The rheumatic fever hadn't gone away, so she was still irritable, febrile with a high CRP. So she had to spend another month in hospital before the episode of rheumatic fever ended, and she was ready for discharge. Now, good news is that I caught up with Brooklyn just the other day at a Parliament House when we launched a movie, and she's looking good, she's full of life, she's got no limitation to what she can do today. But the real question is, what is it that we could have done to prevent Brooklyn needing open heart surgery? Okay, it's a big deal having open heart surgery at age 7. So what is it that we could have done? Since the diagnosis of rheumatic fever, Brooklyn did everything what a doctor has asked her to do. The family were on board, and they just did everything. So Brooklyn swallowed every single tablet, every single medication, she had every single injection on time. Yet she still had open heart surgery. Why? Because the first time she had rheumatic fever, it was so severe. Now, she's really unlucky, because when young people get rheumatic fever, only about 10% of the young people start with severe valvulitis during the first episode. Most people are quite lucky. So 90% of young people, when they have rheumatic fever, they're quite lucky. They've got mild rheumatic heart disease or no rheumatic heart disease. And it's the repeated episodes of rheumatic fever that leads to progression of valvular lesions. And this is what Bart talked about earlier on today. But the 10% of the young people are unlucky, and they end up in Brooklyn's space. So what we could have done is addressing the social determinants of health. So better education, better housing, better transportation, and better hygienic practices. That would have helped with the transition of strep in a household. So that would have minimized the chances of Brooklyn contracting a group A strep infection. We know that Brooklyn had a lot of sore throats and a lot of skin sores. We could have prevented her heart damage and her open heart surgery by making sure that every single time Brooklyn had a skin infection or a throat infection, she would have got treated. And it was quite difficult, because when we made some home visits on any given day, someone in the household would have had a group A strep infection. But these are the things that would have made a difference. These are the things that we could have done to stop Brooklyn having an open heart surgery. So she really didn't benefit from secondary prophylaxis from the 4 weekly injections. So what's Brooklyn's future? How long is she going to live? Is she going to do all right? Is she going to have 3 or 4 open heart surgeries? Or is this it? Well, it really depends on how well she sticks to the program. Secondary prophylaxis didn't help her stop getting open heart surgery, but now this is her chance to go onto the program, get her injection on time every time, and to prevent a recurrence of rheumatic fever. Her risk of having rheumatic fever recurrence is extremely high. It's not high, it's extremely high. So she needs to stick to the program. And this is just the red line, some data from New Zealand showing that the New Zealand kids, the Mara kids who live in New Zealand and had open heart surgery, a single mitral valve repair at the Starship Hospital, they did really well compared with the patients in black who individuals had mitral valve repair but returned to the Pacific Islands. Their prognosis was much worse. And it's hard to know why exactly. Perhaps they had more severe disease, or perhaps they had their secondary prophylaxis was less complete. So the data is missing on that, but we know that if you live in a reasonable place and you have reasonable follow-up, you seem to do better than if you don't. So what we need to do for Brooklyn is she needs 13 out of 13 injections. She needs to have every single injection time, 0 days at risk, as Keith Edwards would say. And because 80% is just not good enough when you have such an overcrowded household. She's going to be exposed to strep all the time. So this is Brooklyn's journey. Now, I would like to share Liddy's journey, completely different altogether. But at the same time, he ended up in the same operating room at the Royal Children's Hospital in Melbourne. But his journey is different. So Liddy, from Belgium, he presented once again to the Royal Darwin Hospital at age 3 with polyarthritis, fevers, raised CRP, and a positive streptococcal titer. So 1 major and 2 minor. And he was only 3 years old, and a very clever paediatrician looked after him, even though he was only 3. He said, well, this is acute rheumatic fever, and he needs to go on to the 4 weekly injections. And that's what was prescribed. But, you know, Liddy lived in a quite tricky environment, a lot of social issues on the background, drugs, alcohol, housing issues, and a whole array of other problems. Importantly, at age 3, when he had an echocardiogram, his echocardiogram was completely normal, so he had no carditis. So what you could say is Edward actually kind of put his hand up and said, excuse me, doctors and nurses, I'm at risk of rheumatic fever. I'm the 3%. I'm the 3% who's at risk. Can you please look after me and protect me? And all he had to do at that stage is to get his injections on time every time, and he would be just right. But that's not what happened. At age 7, he returned with another episode of rheumatic fever, and by this stage, he had severe double valve disease, so severe aortic and mitral valve disease. At age 8, he had a further episode of acute rheumatic fever recurrence, and that led to his first open heart surgery. Now, at age 8, he underwent aortic and mitral valve repair, so double valve surgery. And the family thought, that's great. Surgery, all fixed, he's cured. Life back to normal. But we all know in this room that surgery doesn't fix rheumatic fever, rheumatic heart disease. It fixes the doors and the valves, but a child who was susceptible to rheumatic fever for whatever reason is going to be susceptible after cardiac surgery. So very soon after returning from Melbourne, Liddy had a further episode of rheumatic fever, or suspected episode of rheumatic fever. He didn't undergo the full investigations, so he only met the probable criteria based on the guidelines. So that led to a further open heart surgery at age 9. So just a year apart, he's having his second go. And his first operation was a great success with fantastic results, by the way. It wasn't a surgical technical failure. His second operation was a triple valve surgery, so aortic, mitral, and tricuspid. I met Edward, or Liddy, at age 14, when he presented with endocarditis. He was very crook. He received his 6 weeks of antibiotics, and he got better, but then he was lost to follow-up. Then he represented a year later when he was coughing up blood, so very critical mitral stenosis. He barely survived to his open heart surgery, which you just saw on film. And by age 15, he underwent his third open heart operation. This time it was double valve replacement of the aortic and the mitral valves. So here we had a kid at age 3. All we had to do is give him injections every 28 days. Okay, it's hard work, right? But that's all we had to do. Now as a team, what we have to do is give him daily warfarin medication, fortnightly INRs, 4-weekly penicillin injection, because he could still get rheumatic involvement of his tricuspid valve, and a whole lot of other things, seeing cardiologists, having echocardiograms, and so on. So Eddie is very different, Liddy is very different from Brooklyn. So what is it that we could have done to stop Edward needing 1, 2, or 3 open heart surgeries? So the answer in this case is pretty simple. Stick to secondary prophylaxis. We know it works. We know that intramuscular injection works much better than oral tablets. And this is an old paper from New Zealand some 10, 15 years ago, showing how individuals who go into oral therapy as secondary prophylaxis, it just simply doesn't work. And within 5 or 6 years, up to 35 of patients will have a recurrence of rheumatic fever. Now, you know, the natural history of rheumatic fever, if you're not on penicillin, is not that different. If you don't go on penicillin, then the numbers are about the same. About 30-40% of patients will get a recurrence within 5 years. So it's fair to say that oral penicillin is as good as, you know, gargling salt water. The health team, you know, in the Northern Territory, our nurses, our doctors, our social workers, our Indigenous health workers, we all tried. Everybody tried. We tried very hard to get Liddy to have his injection. And to the point that in 10 years, he was diagnosed in 2003, and by 2013, which is exactly 10 years apart, he meant to have 13 injections per year, so 13 times 10, that's 130. So in 10 years, a patient meant to have 130 injections. And the team quite successfully managed to deliver 65, which is, you know, not nothing. Better than Western Australia. So 50% injection in Liddy's case equal to 3 open heart operation. So might as well have done nothing. So it's really important to, you know, in an environment, in our situation, which is different from Western Australia, in the Northern Territory where housing is really poor and overcrowding is an issue, and there is strep everywhere, when you're protecting people 50% of the year, it's probably just not good enough to prevent rheumatic fever recurrence. In army barracks, it might have been different, because they might have only been in the barracks every now and then, not continuously all year long. So, Liddy's future, you know, he's now 18. How long is he going to live? What's his prognosis? This is data from Jonathan Karapitis, who's arrived from Perth, sitting at the back. The life expectancy of an Indigenous child in the Northern Territory following mechanical valve replacement, the median is around, you know, 15 years, 10, 15 years. So the expectation is that Eddie had his double valve replacement at age 15. He'll be doing pretty well to make it to age 30. But it's not just about staying alive. There's data from New Zealand to suggest that these kind of kids with mechanical valves and all the issues around adolescence and everything else, the odds are that within 10 years, they've got about 50% chance of having a stroke. So it's not just about being alive, but being alive and being able to contribute to society. And it's even more than that. I mean, how many years of education did Liddy miss out on? He couldn't go to school. His family were affected. You know, Liddy did get his Year 12 certificate just the other day, which is fantastic. But how much more could he have done if he didn't have to have 3 open heart operations? So warfarin is a difficult drug. 49% of patients in the Northern Territory with warfarin have rheumatic heart disease. And it's not just difficult in our population. It's not about being Indigenous. It's pretty difficult all around the world. It's a tricky medication, lots of side effects. And in fact, in the Northern Territory, our complication rates are lower than the meta-analysis. But it's still a pretty horrible medication to take. So this is the regime that Liddy is currently sticking to. As you can see, it's pretty complex. He's seeing a doctor most days, most weeks, and he's doing good. But as I said, why did it take 3 operations to do that? Surgery is not a cure. surgeries, palliation. And our two movie stars travelled on gravel roads without any signs or alerts or warnings, and I think what RHDAustralia and the control programs are doing is, putting a paved path, paved road for our patients, and putting some alert signs, warning signs about strep, camels and wombats, just so the patients know what to watch out for. Because Brooklyn's family didn't know about strep causing rheumatic fever, and Eddie's family did know, but perhaps didn't understand the case. And I suppose to close the gap, not this gap, but the real gap in Indigenous health, we need to work together and to work on rheumatic fever and rheumatic heart disease. And communication and talking with Indigenous health workers is critical. As the last point to make is that, my colleagues went to Alice Springs recently and did a cardiology clinic, and Marcus Hilton. And one of his patients said, "Look, Dr. Marcus, I trust you, and I need to talk to you about something really important. A government is trying to close the gap. Now, this gap is pretty important in Alice Springs. The train goes through, the road goes through, the Todd River goes through. What am I going to do when they close the gap? How am I going to see to my family and do the shopping?" So when we're talking about rheumatic fever, we also need to get our communications right. Thank you.